fatality website, you'll see a slightly different number. If you go to CDC, you'll see a slightly different number. Sometimes that's because of lags and them picking up data. Sometimes that's because of where they're pulling the data from in terms of they only look at electronic lab reporting as an example. There's a whole array of issues that can create problems or discrepancies, I guess would be the best way to describe it. But I feel like our data is the most accurate and reliable, and we try to be transparent in making that available to everybody. So this is an update of where we're at currently in the state. Not a good set of numbers, not anything I'm pleased with. Certainly gives us cause for concern in many cases. What we've seen in terms of the pandemic over time within our state is we saw initially when it was introduced back into March and through the summer, it initially had a heavy emphasis and impact on urban areas, and particularly long-term care facilities being impacted in terms of deaths. What we've seen since the fall and certainly into the winter is a shift to the rural and a general population. And so you can see some numbers there that we had a peak at 1.54% of the deaths in Oklahoma were among long-term care residents, even though they represent like 1% of the state's population. That was a point where we were really struggling with control and containment in those facilities. That was very concerning, and we're glad that we've been able to bring that under control much better. Currently, 31% of deaths are from long-term care, and this is cumulative, okay? So this is accounting for all of this heavy loading that we had at the early period. When you look at what it's been recently, it's oftentimes been a quarter or less of recent deaths have been from long-term care facilities. There's two ways you can look at that. One is to say we're having success in the long-term care population and such circumstances. The other, of course, is to say that we're having failures in the general population, and those numbers are getting out of hand. We'd love to see it drive down in both of those populations, but that's where we're at. Honestly, it's a little hard. It's arbitrary how you define urban and rural. Glenn worked with me and some other OSU faculty at the beginning of kind of coming up with our classification characterization of rural and urban portions of the state. It's not universal by any regard, but the way that we've broken it down, it represents about 54% of the population is in urban centers, obviously primarily Oklahoma City and Tulsa, but we include Muskogee and Lawton and other smaller areas as well. But roughly 54% of the population of Oklahoma we classify as urban. And there was a point where nearly 2/3 of cases were in urban communities. We now see a shift to 48% of cases in urban, meaning 52% of cases are in the rural communities, even though they only represent 48% of the population. And I should emphasize that this 48% is not cumulative. That 48% is looking over the last 2 weeks, I think, kind of classification. Any questions on any of that? Again, I don't know that any of those numbers are particularly proprietary. We've got the urban classification, it is ours, but I think everyone's seen that same trend. So any questions on any of that at this point? Thoughts? If not, from a historic perspective, kind of looking all the way back to the beginning and through where we're at right now, there have been about 344,000 cases reported in the state. This represents about 9% of the state's population that has been diagnosed with COVID. We most assuredly know that a larger percentage than that have been exposed. Just like I said at the beginning with the 22% positivity, we know that we're missing a large number of cases. We're not diagnosing them. And so we know that that's an undercount of the total case burden in the state since the beginning. we've documented 2,882 deaths reported, which gives you a rate of 72.3 deaths per 100,000. But it's important to note that that 72.3 deaths per 100,000 isn't actually a rate, and I don't want to get too wonky in terms of epidemiology here, but there's no time component to that. That's just looking at basically what percentage of the population has died due to this disease since it was introduced. And then the final bullet here says the serologic evidence combined with some modeling, again, that Glenn helped with, and I've continued to work with some colleagues to devise. That suggests that greater than a quarter of the state's population have been exposed. Some values would even put that up to 30+% of the state, roughly a third of the state having been exposed. Now, a key thing here, though, is to say that we don't know that that means that a third of the population is protected. We don't know the duration of immunity. We have documented reoccurrent infections to have occurred. And so we don't want to just write off these people and say, okay, they're not at risk anymore, we don't need to worry about them. There's certainly been a strong push all along to oppose anything such as an immunity passport, where once you were shown to have been infected, you can go free and not have to worry about mitigation steps or anything like that. There's a great resistance to that because the science does not support that. So while really what that is there to show is that again, we know that we've greatly undercounted the number of cases in the state, and we're certainly struggling to track its transmission effectively throughout the state as well. If we want to put the fatality numbers into perspective, the easiest way to do that is to compare to other causes of disease. And my apologies, I put this together this morning, so this is fresh off the presses, but I see a mistake here. I've got a redundancy in COVID since March, and this one is wrong. So I'm just going to whack that out and get rid of it. So what you see here is these are the 10 leading causes of death in the state of Oklahoma from the year 2018, which is the most recent year that we have comprehensive data from. And Oklahoma is pretty similar to the rest of the country in terms of where these diseases fall. We have heart disease being the leading cause of death, with over 10,000 Oklahomans having died from heart disease in 2018. That translates to a death rate of 269.7 per 100,000 over the course of that year. Or if you just divide that by 365, it comes out to be about 29 deaths per day, is how you get to that 10,633 number. Cancer is the number 2. You see the numbers there. Then you have chronic lower respiratory disease, accidents, and so on and so forth. Those are the 10 leading causes of death in the state of Oklahoma. The only infectious disease you would find on that list from 2018 is influenza and pneumonia, and it tends to come in that 7 to 8 ranking, which you see here, it was 8th in 2018, causing 807 deaths. If you amortize that, so to speak, over the full year, 365 days, that translates to 2.2 deaths per day. Of course, flu isn't a year-round phenomenon, it's a seasonal phenomenon. And so if you truncated that, just called it 4 months, then you would triple this and say, an average 6.6 deaths per day throughout the flu season, something like that. But that gives you a perspective. When we look at COVID relative to that, as I said on an earlier slide, we now have 2,882 deaths documented from COVID, and that's been since March. If you look at that on a death rate and you again amortize that to an annual basis, you end up with 87.6 deaths per 100,000 over the course of 365 days. Okay, and that's the only way we can make this comparison fair, right? Is to say that it took 365 days to have this many deaths due to heart disease or cancer. We've not had 365 days of COVID, so we need to account for that. and that translates to 9.6 deaths per day in the state. So since March, COVID has been the third leading cause of death in the state of Oklahoma, more than likely. And I think it's always worthwhile to note, even in saying it's been the third leading cause of death in the state of Oklahoma since March, that includes the shutdown period, right? That includes all those extraordinary mitigation efforts that we took in March and April, and really didn't see cases start hitting the state until June. And even through the summer, it was rather quiescent. And so if we actually look at put it more into perspective of where we've been in the last 7 days, that we've had 210 deaths reported in the last 7 days. That obviously averages out to be 30 deaths per day, which makes it the leading cause of death in the state of Oklahoma for the last week. I find that very sobering. I find that very concerning. And I think that's probably the best way to put it into perspective, that COVID most assuredly is not like flu in any form, shape, or fashion, and is certainly something that we need to continue to be vigilant about and concerned about. Any questions on any of that before I move into vaccination?
So I would just, this is Scott Petty from Stillwater Medical. I would just be curious to know if that fact, what you just ended with there, is how does the state use that information? I mean, that's very bold, italics, underlined, exclamation point. How does our governor look at that? How do we get that information out there to emphasize that?
So that data is presented basically on a daily basis to the governor and to the governor's staff. It's reported, and again, these are numbers that are publicly available. We brief the legislative caucuses weekly as well. So our state leaders are aware of these perspectives. They're in obviously the very difficult, challenging position of trying to balance all sorts of interests and concerns. And so, I've always emphasized that I'm there to be a resource for the science and for the characterizations. And those individuals are the decision makers and the action takers, and how they use that information is up to them. We certainly know that there have been a lot of impacts from the mitigation efforts and steps and those kind of things, and so we again try to put the data out there and allow those individuals to utilize it as they see fit. Any other thoughts, questions, or comments?
I just have another. Can you address the contact tracing and how that's kind of gone away, and how that's maybe playing into these numbers a little bit, and maybe even the White House recommendations? If you could address why it sounds like we're not taking that counsel anymore, and maybe that's too strong.
So the contact tracing, the case investigation and contact tracing work is really, really critical and important. And I think I appreciate that question, because I think it hopefully gives me the opportunity to give everyone a perspective here. A lot of people are very unfamiliar with public health as a discipline, and certainly a historic perspective of public health. Contact tracing and case investigation are nothing new, nothing novel at all. Anytime we have a case of mumps or measles or tuberculosis or even HIV in the state, we do a case investigation and many other diseases as well. Let me be clear. Many other infectious diseases, we have a case investigation and we do contact tracing for those diseases. The public doesn't hear about that very often for a whole array of issues, primarily being that we just don't have that heavy of a burden of other infectious diseases. And we're thankful for that. In some ways, public health is a victim of our own success. We've driven so many diseases, infectious diseases, into containment that the only infectious disease many people think of is flu. And they say, well, it comes around every year. We've got a vaccine for it, but it doesn't work that well, and it kills people every year. And why are we so much more worried about COVID than we are influenza? Well, the reality is that influenza is the exception, not the norm. And case investigation and contact tracing are integral tools to containing any of those infectious diseases. However, they're resource intensive, very demanding and difficult to do. And ultimately, they require compliance and cooperation. And what we've struggled with from the beginning is all of those limitations, the resources, the compliance, cooperation, and all of those things. We still continue to do, as we always have, case investigations and contact tracing. However, we try to be pretty blunt in acknowledging that our resources are overwhelmed in those tasks. They just are. We had a fabulous system that was devised by my predecessor and implemented under, earlier in the process, what was called Shepherd's Mall Contact Tracing Center, where they were doing much of the case investigation and contact tracing throughout the state. That has been shifted in structure. We found that those individuals don't need to be in a centralized location. They're working basically to do those tasks throughout the state. So even though we no longer have a facility in a physical place, we still have all those personnel doing that. But again, they're simply overwhelmed. And then the second part is the lack of cooperation and communication that we have among our cases and compliance among those individuals we reach out to. We've averaged somewhere between 2 to 4 effective contacts reported per case throughout the pandemic. In other words, the standard definition is, who have you had physical contact with? Who have you been within 6 feet for 15 minutes? Who have you been in a situation that poses a high risk of transmission? Singing in church, being in choir, participating in group activities, sports, those kind of things. We ask people that from the period back to 2 days prior to test positive or symptom onset. And on average, people tell us they've interacted with 2 people, 2 to 4 people. We know that's not complete, right? We know that is not actually giving us all of the people that those individuals have worked with or contacted. And so we continue to reach out to those people that we get told have been contacts and inform them and advise them of the expectations. But the reality is, when you take into account the fact that we have 40,000 cases roughly active in the state that we know of, I would speculate, I told you earlier, the percent positivity, we can't tell you what that translates to. I would speculate we're roughly a third of diagnosed cases. There's probably 120,000 people or more throughout the state right now who are infectious. We're detecting a small proportion of them. They're not always complying and with when we tell them to isolate. They're not cooperating and providing us the names. When we reach out to people, they're not complying when we tell them to quarantine. And so we're very hamstrung in performing those basic fundamental public health tasks of case investigation and contact tracing because of the numbers, simply overwhelming the resources that we have available, and then the difficulties we encounter with the Oklahoma populace as we interact with them. I'm being really blunt there.
This is Michelle Neighbors. I have a question too, real quick, if that's okay.
Yes, please.
So the UK variant you hadn't mentioned yet, maybe you were going to get to that, but my understanding is that they found that because they have kind of a national systemic process where they're looking for different genetic variants, and that here we kind of have a state by state approach to that, and some states are kind of doing more than others. Is Oklahoma like looking for that? Have we not found it because it's not here, or have we not found it because we're not looking?
And I'm going to check the chat here just in case I missed anything. I haven't been following the chat, so that's always a good place to be looking. So, all right. So to that question, the UK variant, little bit of perspective and background, viruses mutate all the time, right? That's just a continual phenomenon. And we've seen that throughout the pandemic. You have to do full genome sequencing, or at least targeted sequencing, in order to find those mutations. And it does give you information, worthwhile information to do that, but it's certainly not worthwhile to sequence every isolate by any regard. We don't even isolate, these viruses. We're doing a sampling that's only looking for a small portion of the DNA or the RNA, excuse me. We can amplify out of that. Again, because I'm kind of getting into the weeds there, my apologies, but that is a surveillance tool to try to look for those. The UK variant is unique in that it has a relatively large number of mutations, and those mutations have been retained and propagated relatively quickly, which suggests that there's actually evolutionary pressure supporting those. There's an advantage to those mutations, and that's why it's persisting. It's important to recognize what's a virus's goal, so to speak. They're not sentient beings, obviously, but what would they be striving for or seeking if they were? It's simply to replicate. And any mutation or variation that makes it more efficient at transmission or dissemination is going to give an evolutionary advantage and is likely to be retained, assuming that it doesn't come at an excess cost. And so all indications are that several, if not all, of those mutations seen in that UK variant actually do confer some degree of benefit to the virus in terms of transmissibility. The good news is it does not seem to increase the virulence or risk of causing severe disease, and we're very appreciative of that. And it also does not seem to it does not at this point appear to pose a risk of escape from vaccine-induced immunity. We're very appreciative of that. That's something we're going to continue to have to keep an eye on, but we're glad to see that. So all that's some background. Now to your point of what are we doing in terms of surveillance for that? We do not have a rigorous, robust, systematic surveillance method for that, in part because of the disseminated nature in which we do testing, right? Testing is done at the public health lab, but testing is also done at a whole array of private and public labs and healthcare facilities, and now even down to the point of long-term care facilities and schools. And so we don't have a systematic way of having a repository of those samples being retained and submitted for sequencing. We have done some sequencing throughout the pandemic in the state. Much of that has been for academic purposes. And obviously now that we know of the UK variants, specific genetic markers, and we can look for that, we are going to be examining for those, the sequences that we have, and putting those into a phylogenetic tree. I see no reason to believe that that strain is not in Oklahoma. And let's just be honest, there's no reason to believe that it's not in Oklahoma. It sort of made news when it was found in Colorado and California and Florida, but none of those individuals who were found to have it had a history of international travel. They almost assuredly had contracted it in the United States. It had been in the United States, and no one had been looking for it very hard. There's nothing that we're going to, I'm not going to tell you to wear a different mask or not wear a mask or wash your hands for 28 seconds rather than 20 seconds. I'm not going to make any change in recommendations based upon knowing that that variant is in the state. I assume that it is. And I advocate that we continue to follow our mitigation steps with the understanding that those mitigation steps may actually be a little less effective with that strain in the state than they were otherwise. But we know what we've been doing has not been effective for whatever strains have been in the state. We need to do better. Other questions here, and comment the fact that the total U.S. death rate is not up year over year for all of 2020. I'm not sure where you would be getting that information from. If you look at what's called excess mortality, CDC publishes this on a regular basis, and excess mortality for the United States is most assuredly up. And it's up not only from a numeric perspective, but actually what we would say is a statistically significant amount, and has been up for a large portion of the year. And we certainly know that it's up in the state of Oklahoma as well. I'll actually try to find that while I'm talking about other things and try to show you that slide that shows that. Here we go. That was quick and easy. So this is U.S. excess deaths. The scale down here is a little hard to see, but this is actually 2018. That was something of a bad influenza year period there. But this is 2020 starting right here. And the yellow line is our line of statistical significance. And any bar above that suggests that we had quote unquote excess deaths, more deaths than we would have expected. And you can see here that those blue bars have exceeded, and oftentimes far exceeded, that yellow line since back here around the end of March, beginning of April. There's always a catch-up period. This bar right here, as an example, will grow. It's going to end up somewhere up here because, as I said earlier, all of those deaths don't get reported immediately. And so the deaths certainly in the United States are up year over year. And this is one way to look at that. This is Oklahoma's excess deaths. You see that our excess deaths kicked in much later, but have been following certainly the same trend since that time. Let's see, I'm trying to follow here along, maybe underreporting of deaths. Absolutely. Certainly there's going to be discrepancies. So I showed, 2018's cause of death. There will be 2020 publication of deaths, and the numbers that you will see at that point will not necessarily match up with the numbers that you're seeing reported out of ours currently, because they use different reporting methods. Ours is based off of a very rigorous public health system scrutiny of all cases. The other reporting is based off of death certificates and how physicians fill those out. And so you're going to see some discrepancies in some of those numbers. That's not conspiracy stuff. It's not anyone trying to be manipulative or deceptive. It's honest mistakes or honest differences just based upon documentation. But we will eventually have a tally of these deaths. The struggle is people want data in real time now at a level that we've never, ever delivered in the past. And the more rapidly you deliver the data, the more crude and inaccurate it's going to be. And the more time you have to double check it and quality control it, the better it's going to be. But of course, it's less value for decision making at that point. So there's always a trade-off at that point. I want to wrap up here real quickly with some information on vaccination. I know there were discussions about that even before we started here. So for those of you who are not familiar, you can see the web link here, vaccinate.oklahoma.gov. We are currently in phase 2. The 4 phases are shown right here. The first phase was healthcare providers and long-term care facility residents and personnel. That's not to say that we've completed phase 1. If you're a healthcare provider and you've not received your vaccine yet, show up, you're still eligible, get in line, we'll put you to the front of the line, we'll make sure you get it. But we have now moved down to the point of also including first responders and any general population greater than 65 years of age. Level 3 or phase 3 will be what's termed essential workers. And then level 4, phase 4 is a general population. You see the numbers here that may not look like a whole lot that's been administered, particularly when you consider we've received 310,000 doses in the state. But what you should know is that roughly 50,000 doses have been allocated to CVS and Walgreens to disseminate to long-term care facilities. That was a federal contract agreement. And we've struggled, as many states have, with those pharmacies delivering the services that they guaranteed. And so that's kind of outside of OSDH's personal control. And so, if you knock off 48,000 or roughly 50,000 of these doses, you're down to 260,000. We've administered 182,000 of those. We've got appointments on the books. And so overall, we feel like we're doing pretty well in that regard. In terms of delivering the vaccine. We're continuing to ramp up. We can do better, and we intend to continue to do better, but certainly this is a task that we've never undertaken before. We've got a question here saying the registered at the vaccine lake, they received a confirmation of the registration. So we had some trouble when that system was first devised. I guess I hearken back to the rollout of Obamacare. If anybody remembers how those servers crashed, that was a federal system that had months and months and months, if not years, in design and creation, and it crashed. We certainly learned from that. We did better, but we certainly had limitations when we rolled our system out. We intentionally slowed it down the first couple of days because we couldn't match input of available appointment times with the number of people who were coming in wanting to make appointments. So rather than telling you there weren't any appointments, we wanted to be slower in responding to you, period. So that's why it took you a while before you received the confirmation of that email. You're telling me here that you've continued to struggle to find openings and slots for that. I understand that. I regret that and hate to hear that. All I can say is continue to check, and we're going to continue to offer those. We just got some rather disconcerting news this morning regarding vaccine availability from the federal side. You've probably heard that the Biden administration planned to release all vaccine for distribution immediately, where it had been asserted previously that they were holding back doses for the purpose of booster delivery. And the Biden administration said, we're not going to hold back those doses. We're going to count on manufacturing keeping up with the demand moving forward for both primary and booster doses to be delivered. And so that's what we were trying to prepare for. We received some somewhat disconcerting news regarding the actual circumstance in terms of the doses being held back. I don't know. I'm sorry to tease and not fully disclose here. I don't know that I'm in a position to make that information known publicly. But I want you to know that we understand, we're taking this seriously. We're doing all that we can. It's just an extraordinarily complicated situation. We've got, manufacturers that are producing these vaccines as quickly as they can. We've got a federal government that's agreed to buy an X number of doses. But that manufacturer has also made contracts to distribute to other countries and other destinations. And then we have all of our states competing for doses from the federal government. And then once we get them into the state, we've got enormous logistical issues of getting them into the right populations across and throughout the state. And so that's not making excuses. We certainly want to do better, and we understand that we do have people who are eligible for vaccines who are not getting them as quickly as we would like. But we are doing the best we can, and honestly, we're doing pretty well. We've consistently ranked in the top 15 of the states throughout the country in terms of doses administered per 100,000 people. We've typically been right around 10th in that number, and we feel good about that. And we've definitely been outpacing the majority of our surrounding states in terms of being able to do that. So we're not resting on our laurels in that regard. We're going to continue to push to try to improve and do better. But ultimately, while it's frustrating for any one individual or family or whatever to not be able to get what they know that they're eligible and entitled to, we're moving along very quickly, and we're excited about that. So we've got a question in the chat regarding zoonotic diseases. Zoonotic disease are diseases that can affect both humans and animals. And the question is that most of the pandemic diseases of the past and current eras have been zoonotic in nature. Is that correct? And yes, it largely is. That's not necessarily an exclusionary category. We're animals, right? And we share a lot of similarities with a number of other animals. And so roughly 2/3 of what are called emerging or re-emerging infectious diseases of humans are zoonotic in nature, are possible of infecting both humans and animals. And so yes, that is very common. That's one reason that I am particularly involved in public health as a veterinarian. That's certainly one reason that Oklahoma and the OSDH has launched the Oklahoma Pandemic Center for Innovation and Excellence. That we recognize that zoonotic diseases are going to continue to be a public health threat, and we want to be prepared to deal with those in the future. Influenza is zoonotic. SARS obviously is, all of the SARS and the MERS that we've seen recently. Tuberculosis actually can be a zoonotic infection. Brucellosis, all sorts of pathogens and agents are possible of being transmitted both to humans and to animals. And so it's very critical that we always take what's called a One Health perspective, understanding that we all live in one world and we interact with our environment and the surroundings and the other beings on this earth very intimately, and our health is very dependent upon the health of all of those things surrounding us. Other thoughts, questions, comments, concerns? I know that was a whirlwind. Quite honestly, I don't know what our time schedule is. I'm not sure if we're going to get zapped for being over 1 o'clock already, or what that is, but I'm certainly willing to entertain questions.
Last chance. Any questions? Okay, seeing none. Thank you, Dr. Taylor, for your program today. We certainly appreciate the timely nature of it and all of your information. Stillwater Frontier Rotary supports literacy, and so we'll be donating a book to the Stillwater Public Library in your honor.
Thank you.
Thank you to all our guests and visitors who joined us, and thank you for those who let us know they had guests with them. Please join us next week for our own Dr. Moore to give us an update on the Stillwater Public School System and its COVID protocols, among other things. If there's nothing further for the good of the club, then we'll finish out with the 4-way test. I'll mute everybody so we don't accidentally get somebody on there. And then if you'll join me with the 4-way test. The 4-way test of the things we think, say, or do. Number 1, is it the truth? Number 2, is it fair to all concerned? Number 3, will it build goodwill and better friendships? And number 4, will it be beneficial to all concerned? Thank you again to our speaker and for everybody that joined us. Have a good week. We are adjourned.
I will say real quick, I appreciate the opportunity. I enjoyed it. Always feel free to reach out to me. I'm pretty easy to access, but if you can't find a phone number or an email, Glenn can get you in touch with me. Anytime I can be of assistance in regards to OSU, OSDH, cattle health, whatever you're interested in, I'll do my best to either answer questions or to direct you to somebody who could. And to Carl, in terms of how do I get the vaccination, stick with the portal. We're going to continue to, that's the preferred and ideal way. But, if you continue to be frustrated with it, you can certainly reach out to your county health department. They're overwhelmed. They're struggling. The portal is certainly the preferred way. But if you ever reach a point that you feel like it's just not working for you, our county health departments are full of wonderful, wonderful people who are working really hard to serve their communities. And that's always an option as well. Thank you again very much. I appreciate it.
All right,
Have a
thank
good
you.
day.
You all have a good week.
Hey, Travis.